Alright, we're going to go over the OBGYN complications in pregnancy now. Alright, so first one, of course, the big one is trauma. Now, trauma can be encompassing of a lot of different things, but there's several different causes that tend to happen more so than others. Motor vehicle crashes, falls, domestic abuse, and then, of course, penetrating trauma. So, as far as, with your abdominal trauma, things like that, the same mechanisms that occur in non-pregnant women occur also in pregnant women. The biggest thing is that the uterus is very, very vascular, and whereas it's very well protected normally in a non-pregnant state, it is not as protected or protected hardly at all towards the end, second and third trimester, because it comes up and out of the pelvic cavity. Additionally, some things to think about is that the center of gravity, the balance point is altered, so maybe a little more prone to falls, that kind of stuff. And with motor vehicle crashes, especially in that last trimester, seat belts and things of that nature may not fit as well, not to mention the belly's poking out some, and so airbags, things like that normally wouldn't be as big of a concern can become more of a concern in that, especially in that last trimester there. So anatomical things to remember when you're thinking about trauma. The abdominal contents are compressed into that upper abdomen. That diaphragm is elevated by about 1.5 inches or so. Alright, so what this means is that when you have abdominal injuries in trauma in a pregnant state, they are more likely to be associated with some chest trauma as well. Alright, and the peritoneum is already stretched out pretty well, so there's not a lot of room for extra movement, if you will. Alright, in the first trimester, like we said, uterus is well protected and rarely damaged from trauma. Second and third trimesters, however, it's up in the abdomen, it's much more vulnerable, very vascular, things are a lot more possibility of getting injured there. Alright, that lap belt and the MVCs, like we said, may compress the uterus, or shoulder restraints, do help some, but that lap belt, if not placed correctly, could cause some injury. Penetrating wounds. So the large uterus protects these other organs actually, but the fetus is more often injured. So, kind of a, trade one for the other. So with your examination of these patients, you may have some abdominal tenderness, you may have abnormal fetal position, you may be able to easily palpate the fetus, you may not. You may not be able to palpate the fundus, the top of the uterus. You may or may not have vaginal bleeding. So just some things to think about when you are examining them. Alright, you're much more prone to an abrupto placenta or a uterine rupture in these deceleration injuries that are often associated with your MVCs. So as far as signs and symptoms, responses to trauma, we talked about earlier about how the the tachycardia is a little more common in the pregnant state, and so that can be a little bit harder to interpret because they've got that increased vascular volume. We already know that their heart rate's increased a little bit, so it can be hard to differentiate normal tachycardia because they're pregnant versus early tachycardia because they may be going into shock. That blood volume can kind of hide the signs of hypovolemia. You may not see the signs the warning signs that we normally look for, the falling blood pressure and things of that nature, may not be evident until they've lost, 30-40% of their blood volume. That's not good. That's late now. So if you have a pregnant patient, if your mechanism of injury indicates the potential for shock, go ahead and be kind of aggressive with your management, your potential shock treatment and management of that patient, okay? Especially, let's say if you think they might have like a pelvic fracture or bilateral femur fracture, something like that, they've got a lot more blood volume in that pelvic region because of that, so a little more likely they could have actually bleed out and die from pelvic fractures. Because remember, they don't usually fracture just one spot, usually going to have multiples there. Your respiratory rate. The reason, remember, our respiratory rate increases. We need to do this because we have to keep up with the oxygen demands of the fetus and the mom. So if their rate is less than 20, be a little suspicious. It may not end up being adequate to get them enough oxygenation. Okay? If you need to provide artificial ventilations, normally we do 10 breaths per minute. We may need to do a little bit more. Right? We may need to actually ventilate, 12, 15 times a minute, and just kind of monitor that tidal and see where we're sitting there. Now, as far as fetal injury, all right, for the fetus in trauma, the uterine wall cushions the fetus against direct effects of blunt trauma, but fetal injuries can still occur from that rapid deceleration or impaired fetal circulation. So if mom goes into shock, it's going to reroute and shunt blood away from the fetus to protect the mom, which can cause fetal demise. All right. Any injury, any significant injury for the mom, especially with maternal bleeding, is dangerous for the fetus, okay? Fetal heart rate is going to be your best indication of fetus status after the trauma. Normal fetal heart rate's between 120 and 160. Any rate lower than 120 is going to indicate fetal distress and it's an emergency. What can you do about it? Treat mom for shock and rapid transport to an appropriate facility that has neonatal care, ideally, if possible. Alright, so what are we going to do? We can only treat the woman directly. We can't treat the fetus in utero. So we're going to try to figure out how far along they are, the gestational age. If they are visibly pregnant, you're going to transport on the left side if there is no spinal injury suspected. We don't want to have any of that supine hypotensive syndrome stuff going on, right? Alright. We're going to look at the fetal heart rate, but we really can't do anything about it. But we do understand, you know to understand that if it is a decreased rate, that does indicate that there's some kind of emergency going on. Right? ABCs are our highest priority. Left lateral recumbent if no spinal injuries. Right? And early fluid resuscitation as needed. Okay, if the patient must be transported supine, try to elevate that right hip about 6 inches. Roll up some sheets or something of that nature to try to help keep the weight off of the vena cava. Alright, so airway, breathing, circulation, ventilations, controlling bleeding as needed, IV, watch and treat for shock, and transport. Okay. If they are unresponsive and the airway needs aggressive management, isolate the airway. You can do an ET. Just remember that regurgitation, aspiration are more likely in a pregnant patient than a non-pregnant patient because of that delayed gastric emptying. So you might be better off if you can get an ET versus a supraglottic airway or something like that. Right, if you have maternal cardiac arrest, provide CPR and ACLS just like you would for any other trauma patient. Your chest compressions may be a little more difficult to find. The landmarks in the 3rd trimester. Use your sternal notch as your guideline for your hand placement. The other thing is that the AHA currently, as of right now, 2021, recommends manual uterine displacement during CPR. So what that means is you need a 3rd person at least. So you need one person standing to the left of the patient, and they will take their hands, find the edge of the fundus and the top of the uterus there, and manually displace it to the left and slightly down. All right, by displacing it like that, that's going to help remove the fetus off of the vena cava a little bit and help ensure that the CPR is able to deliver adequate preload coming back to the heart. So, and you just keep that the entire time. You keep that manual displacement the entire time. Right. This is one of those cases where even if the mom is obviously dead, CPR, ventilation support may give the fetus a chance, keep it more viable, even if the mom is already dead. So this is one of those times where I would probably do CPR and transport even if I know for sure that these injuries are incompatible with life for the mom. Right, next thing is an abortion. Now keep in mind that this is going to be defined as any expulsion of the fetus from any cause before the 20th week of gestation. All right, so this could be a spontaneous abortion, which is often called a miscarriage, or it could be an elective abortion, either carried out by medicine or a procedure. All right, most are going to occur during the 1st trimester before the placenta is fully matured. And with our spontaneous or miscarriages, that occur naturally, it could be from an acute or chronic illness in a pregnant woman. It could be a toxic substance exposure. It could be fetal abnormalities, abnormal attachments to the placenta. There's a lot of different things that can cause a spontaneous abortion. All right. If you have a patient who has had an elective abortion, when you're getting your history, be professional. Regardless of your opinion, your personal opinion on this, your job is to take care of the patient and to provide them the best care that you can, to be compassionate and take care of the patient, not judgmental. All right. Any patient who is pregnant or has been pregnant recently who's presenting with this vaginal bleeding or abdominal pain or anything should be transported to the hospital. Now, a habitual abortion is defined as 3 or more consecutive pregnancies that have ended in miscarriages. With this, your specific causes could be chromosomal or endocrine disorders. There could be some ovarian issues, could be like a uterine malformation where, maybe it's tilted or just not in there quite right. There could be a cervical problem, could be some infections, or even some different lifestyle factors that can contribute to these different consecutive miscarriages. A threatened abortion is where you have vaginal bleeding in the first half of the pregnancy, usually the first trimester, and it can progress into a complete abortion, or it could subside and then everything gets right. So usually treatment for this is going to be bed rest, so the condition can be monitored. Pre-hospital role in this, we may not know if it's a threatened abortion or an actual abortion, so our treatments transport and supportive care. All right. Imminent abortion is just a spontaneous abortion that cannot be prevented. So signs and symptoms: severe abdominal pain from contractions, uterine contractions, vaginal bleeding, may have a lot of vaginal bleeding. They may have cervical dilation. We're not going to know if they have cervical dilation, but it could happen. Pre-hospital goals: maintain the blood pressure, prevent hypovolemia. All right. So we are going to IV normal saline, oxygen, get EKG, emotional support, rapid transport, monitor, and treat for shock. Right, the incomplete abortion, this is where the fetus is expelled, but the placenta is not, so they'll have continual vaginal bleeding. We're going to watch, monitor, treat for shock, start your IV normal saline, and transport to a appropriate facility. We will collect and transport anything that has been expelled. So if you have a fetal tissue or anything of that nature, then it would need to be taken with you. Now with this, depending on how far along they are, it may look like kind of a blob of tissue that's not readily identifiable, or it could look like a fully formed fetus, just very small. So be aware that, it can invoke some very strong emotions, both in yourself, your partner, the patient. If the patient wants to see it or hold it, then so be it. That's fine if they want to. Okay. It's one of those things. It's not going to be an easy call, regardless of what happens. All right. A missed abortion is where the fetus dies in utero in the first 20 weeks, but does not get expelled, so it remains in utero. All right. With this, once again, emotional support and transport. Okay. You're not going to hear a fetal heartbeat. The uterus usually feel like just like a hard mass, almost like a softball type thing. Hospital management is going to be a D&C, where they go and dilate and they kind of clean out the uterus, for lack of better terms. Okay. Once again, same things can cause this: abnormalities, things of that nature. Right? A septic abortion. This is where the uterus has become infected following an abortion. So this is where, we're more likely to get called in. This is where they've had a spontaneous abortion or an elective abortion, and then it's become infected. So they may have a fever, they may have general malaise, they may have a foul-smelling discharge within hours to a few days after the abortion. They'll probably have some abdominal tenderness. This can progress to full-blown septicemia and septic shock in some cases. So treatment: recognition, IV, oxygen as needed, EKG, ECG monitoring, rapid transport, and treatment for sepsis as needed. All right, next one, ectopic pregnancy. So ectopic pregnancy is where the fertilized egg implants somewhere other than the uterine wall, like the inside, the uterine lining there in the inside. Signs and symptoms. Now early on, signs and symptoms may not be any at all if it's very early. Where we usually get involved, or where there's an issue, is when it gets too large and it ruptures. That's when you start getting your abdominal pain, your signs of shock, that kind of stuff. All right, so keep in mind that early on you may not have any signs at all until it gets to the large, and then it gets to that rupture point. With that said, by the time it gets to the point where it causes a problem, a recognizable problem for the patient, it's usually at that life-threatening stage. All right, so signs and symptoms: severe abdominal pain, especially unilateral pain. So if they have lower quadrant abdominal pain in female childbearing age, which, I say 6 to 60 because you never know, consider the possibility of an ectopic pregnancy, okay? You want to treat and monitor for hypovolemic shock, and just be very, very aware of this. It needs to always be in our mind as far as a differential diagnosis for some of these patients. Okay, so 3 signs of your implantation in your fallopian tubes are going to be abdominal pain, a delayed menses where they've missed a cycle, and potential for abdominal bleeding, spotting, things like that, 6 to 8 weeks after their last normal menstrual cycle. So causes: just a fertilized egg has implanted somewhere other than the uterus, okay? Usually this occurs in the fallopian tubes, but it can happen within the cervix, on an ovary, in the abdomen somewhere, but most commonly it's going to be in the fallopian tubes. Okay, so treatment: we're going to treat for shock. Treat for shock and rapid transport to an appropriate facility. So an appropriate facility in this case ideally would have OBGYN, but at minimum would have abdominal surgical capabilities. Next one's going to be placenta previa. So a placenta previa is where the placenta is implanted very low in the uterus and is either partially or fully covering the cervical canal. So this leads to vaginal bleeding in that 2nd and 3rd trimester. Being older, having high maternal age, and having multiple births before can lead to or contribute towards a placenta previa. Right? And some complications potentially could be like a hemorrhage, low fetal birth rate, disseminated intravascular coagulation, or DIC. Signs and symptoms: usually it's going to be painless vaginal bleeding, and it's going to be more of a bright red blood. Uterus is going to be soft and non-tender. Right. Now, I'm going to throw this out here. If you have a woman who has 3rd trimester bleeding, do not palpate deeply on the uterus. Okay, don't dig in deeply when you're palpating that abdomen, because you can make that bleeding worse. Okay, you can induce heavier bleeding. Causes, like I said: advanced maternal age and having multiple births prior. So treatments: left lateral recumbent position, O2 as needed, IV as needed, shock management, trauma pads placed loosely over the vagina, nothing goes in it. Right? This is not something we can fix in the field, and if you have a delivery where they've been told they have placenta previa, we're not going to be delivering in the field as well, or with this. Alright, abluptoplacenta. So this is a premature separation of the placenta from the uterine wall. It is more common in the last trimester, but can happen in the 2nd trimester. Alright, sudden onset, or signs and symptoms: sudden onset of abdominal pain, no longer feeling the fetus move. Vaginal bleeding usually is going to be a dark red blood. Right? Physical exam is going to reveal signs of shock, maybe a tender abdomen, perhaps a rigid uterus, and they may have absent fetal heart sounds, depending on how long this has been occurring. Right? Causes: hypertension, trauma, drug use, alcohol use, diabetes, just having had multiple pregnancies, being pregnant before. So, lots of different things here that can cause it, and sometimes it just happens. So what do? We're going to put them in left lateral recumbent. We're going to give them oxygen as needed. We're going to give them an IV as needed. We're going to treat for shock, trauma pads. There's not a lot we can do, but the big thing here is recognition, because if that placenta is separated from the uterine wall, that fetus is not getting adequate oxygenation and gas exchange through maternal blood supply, so that baby will die. So it's real important for recognition and transport to an appropriate facility. Preeclampsia. Right, so risk factors: first pregnancy before age 20, so a younger pregnancy. Right, being older and advanced maternal age typically is considered to be above 35. So anybody above 35 is considered to be what they call a geriatric maternal age or advanced maternal age. Right, having a history of multiple pregnancies, having high blood pressure already, having renal disease, having diabetes, all of these things kind of increase that possibility of having preeclampsia. So your signs and symptoms here usually are going to show up around week 20 or so, and you'll have this triad of symptoms. So you'll have edema, usually will be like the face, the ankles, and the hands. They'll have a gradual onset of hypertension, where it'll just go up, 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 and they'll have protein in the urine. They also may have, especially as it progresses, severe headaches, nausea, vomiting, agitation, a rapid weight gain, and they may have like visual disturbances like spots in their vision, things of that nature. Right? So with your preeclampsia, not super common, but they may require emergency hypertensive medications. This is going to be one of those contact your doc and find out, and contact their doc and find out, right? And probably if that is the case, you would be using hydralazine or labetalol. But that's not a given, it just depends on the situation, okay? Some other conditions that can kind of come along with the preeclampsia: renal failure, liver failure, cerebral hemorrhage, abrupto placenta, and the HELP syndrome. So the HELP syndrome is the hemolysis, elevated liver enzymes, low platelets. And basically, this is just a disorder that can occur. It's very, very serious disorder, and it can kill the mama, but it's going to occur with this preeclampsia. So if this occurs, we need to transport them to an appropriate facility that has a very good OB/GYN neonatal floor. Right, eclampsia. So we all know preeclampsia, right? Eclampsia is when we have preeclampsia, but now we've progressed to seizures. Right? The cause is untreated preeclampsia. Right? And a lot of times we don't get them with the preeclampsia, we get them once they start seizing. Right? So it's real important that we find out what kind of history that, what the doctors have said, that what's been going on, that kind of stuff. Right? The treatment can be real difficult because the drugs that we use could cause fetal distress, and we don't want to do that, right? So with this, our recommended treatment is going to be magnesium sulfate. Right, magnesium sulfate, and the exact amount may vary depending on where you are, but typically it's going to be 4 grams. Now, you could potentially give it IM, 2 grams in like each shoulder or each hip. The problem with that is that when you give mag too fast, it can cause respiratory depression. And we don't want to do that because we already know that their respiratory needs to be a little bit faster because of everything that's going on. So typically we're going to give mag sulfate in an IV drip over, 15-20 minutes, somewhere right around in there. All right. And keep in mind that if they start showing signs of respiratory depression, if they're starting to show signs of magnesium overdose, our antidote for that's going to be calcium chloride or calcium gluconate, okay? Some other potential complications that can occur: abrupto placenta, hemorrhage, DIC, and death. Now, with your seizures, if the magnesium cannot control it and they are still seizing, if we hit status, okay, that is an absolute life threat for the baby as well. That is the point where you might want to consider some Valium. And yes, it will cross the placental barrier. It will affect the baby, but we have to get those seizures to stop, or that baby's going to die either way. All right, be prepared if that occurs and you do end up delivering that baby may have some respiratory depression, is probably going to have some issues. So you're going to want to make sure that you've got some more help on the way and that you're taking them to an appropriate place with neonatal NICUs. All right, chronic hypertension. So with this is having blood pressure higher or equal to the 140/90 before pregnancy or before the 20th week of pregnancy. They are at a little bit higher risk of stroke or other, cardiovascular complications. All right. Hypertension before pregnancy or being borderline hypertensive before pregnancy is what's going to cause this. So what do? We may consider some antihypertensive medications if they're showing signs of a hypertensive crisis. Labetalol, hydralazine. As always, mileage varies. I would contact med control before you make that decision to give a pregnant lady some blood pressure controlling medications. Remember that blood volume's more, their cardiac output is increased. There's a lot of different changes that have occurred here. All right, supine hypotensive syndrome. So with this is where the uterus, when they are laying supine, the fetal position in the uterus is actually compressing either the lower iliac vein or the inferior vena cava. All right, it takes several minutes of compression before the signs and symptoms start to show. So they're not going to do it immediately. All right, but the early signs: nausea, dizziness, tachycardia, and claustrophobia. The later signs: difficulty breathing, and they may have a syncopal episode. All right. So, like I said, occluding venous blood return back to the heart, which is going to decrease preload, decrease cardiac output. So, what do? We put them in the left lateral position. We treat any underlying causes, monitor blood pressure, vital signs, ECGs, transport. Gestational diabetes. So, they may show signs and symptoms, they may not. But this is where you have an increased maternal insulin production that causes an imbalance between this glucose and insulin. All right, they may have that polyuria, polydipsia, polyphagia. They may not. Treatment may be just diet control, or they may take hypoglycemic medications. As far as us, if they are showing signs of hypoglycemia, IV glucose. Treatment's the same. If they're showing signs of hyperglycemia, IV and fluid. So nothing has really changed as far as our paramedic treatments. We treat them just the same as we would as if they were not pregnant.